Good evening. This is the CAFP's Community Conversations session for today, April 19th. I'm Shelley Rodriguez, the Deputy EVP here at the Academy, and thrilled to welcome all of our viewers this evening and to thank you for spending an hour with us on a Sunday evening. Tonight's topic is what's happening in testing. Huge question. Everyone's interested. Everyone seems to have an answer, although nobody really has an answer. So tonight we've brought together a group of your colleagues, Drs. Kim Yu, Anthony Fach-Chang, Ted O'Connell, Raul Ayala, and Lee Ralph, to take us through some of the testing questions they're seeing in their communities, in their institutions, in their organizations, and in their practices. This is also your time, so please feel free to post questions on Facebook. Those questions will come to our panelists and we'll get as many of them answered as possible. Couple ground rules as we get started. We are live streaming on CFP's Facebook page, so please remember others might watch and read your comments. Please type questions and comments into Facebook. We'll watch them and we will do our very best to get to as many of them as possible. We're going to apologize in advance if we don't get to you, but we do save the chat box and try to respond during the week. We're also very happy to be offering one AAFP prescribed CME credit for this live activity. So if you want to claim your credit, go to this link and we'll type it in the Facebook box. So that you are able to go to the link, fill out a very quick survey, like 6-question survey. One of the questions being, what other things would you like to hear about, and get your CME credit. We're also recording this session tonight, and it will be up on CAFP's COVID-19 page within a day or so, so that if you weren't able to watch it, or if you have colleagues you think should watch it, it'll be there and available. We do a conflict of interest disclosure. It's our policy. It's part of CME to ensure that anyone with influence on the content does not have financial interest. And all of our panelists have declared no activity indicated for relationships. Clean as a whistle, as Dr. Tom Bent would always say for us. Objectives this evening, we want to discuss kind of current testing issues in California communities, want to analyze some of the opportunities to address testing and to answer your patients' questions, and to talk a little bit about some of the point of care that's being used, antibiotic testing, contract tracing, and more. I'm going to start off with Dr. Kim Yu. Kim is the Regional Medical Director in California for Aledade. Kim, just tell me when you want me to move and I'll press the slides for you. Kim has just a few slides. Then we're going to go to Dr. Anthony Fach-Chang, who's with Scripps Medical in San Diego.
Thank you so much. Thank you so much, Shelley. Yes, you can go to the next slide. I'm with Aledade, and we have 29 practices now with 100 physicians, family medicine internists in those 29 practices throughout Northern and Southern California. And I wanted to talk a little bit about what we're doing with testing. Nationally, on a national scale, we know that 80% of primary care practices are having high levels of stress. And this was surveyed by the Larry Green Center. The Primary Care Progress team did this quick COVID primary care survey of 1,000 practices. And they found that 58% had a persistent lack of PPE and testing, that many were using used or homemade PPE and reusing, and that between 30 and 40% really had no capacity or limited capacity for testing, with lots of different variations in testing differences throughout the country. Next slide. When we look at California, what we were finding was that it truly was PPE dependent as to whether practices were doing the testing in office, or should I say specimen collection in office. Many were triaging by phone, and patients that needed testing would actually be asked to come to drive-through specimen collection if they had PPE. If they weren't doing drive-through, then maybe they would have a separate section of their practice that was designated where they would do the collection of specimens. and to be able to bring them through a separate door and make sure it was just one person that was meeting them at that door, bringing them to that room, doing the testing, making sure the room was really cleaned in between, opening the windows, things like that. But it was totally dependent on whether PPE was available. Many were also sending to the health department. And what we were finding was that the health department actually were changing where they were doing testing, because they didn't want people collecting or staying at one spot, like maybe it'll be at a church or a community center. And so that those change rapidly throughout the week, sort of every 2-3 days, like everything would be different. And so it was really important for us to keep track of where the testing centers were, because it really would change often. We did have one practice that actually assisted a hospital in doing a drive-through in their parking lot. And the hospital was really wonderful in providing PPE for that person, because they were able to help at that hospital with their testing there. There are also some who are participating in the Verily project, which is the Google project that had been touted, and but there's lots of restrictions. You have to be over 18, you have to drive, you have to have a Google account, internet access, so it's limited to those that can really do those, and you have to also pass a screening test. There are many different types of tests, but there are currently no FDA approved or cleared diagnostic tests. They're all under an emergency use authorization, and they're either classified H&M. It's not the store, it's just H&M for, making sure that you use a clear certified lab only. And you also have tests that are W, which are clear waived, right? And I wanted to just put here this clinical significance, because many people have said, maybe there is this significance to us doing antibody testing. However, there are many difficulties with antibody testing. Next slide. If we look at the tests that are available, and we can move to the next slide, Shelley, thank you. This here, the next few slides are for information, and I wanted to just list the types of tests that are available. I know many of us, when we saw the IgG tests, the Celix test, we were all excited that we were going to be able to get Celix tests, and then we found out that no, those are only to be done at a clear certified lab. And there are many difficulties, because there really is insufficient data to really look at sensitivity and specificity in a meaningful way. And when you look at some of the numbers here, 50 out of 50, 100% positive percent agreement, looks like it's amazing. But really what that means is that they took 50 tests of people who were positive and tested their test against those 50. That's it. That's all they did data on. So it's really hard to be able to extrapolate the thousands and thousands of tests that we're doing with just data from 50 tests, right? Next slide. The next slide actually talks about the clear wave tests. And Shelley, next slide. These are the point of care tests that actually could be done in office settings. However, when we looked at all the different tests that are available, these were the only 3 that could be done, but they're very expensive to perform. The Abbott ID now requires a machine that you need to purchase. We did have a practice that did have the machine, but unfortunately Abbott told them that they were not going to be able to get the cartridges that they needed, because all of those cartridges were being sent to the hospital. Likewise with Mesa, when I emailed them, they also told me that they weren't going to be able to tell me when the tests were going to be available or how much the tests were going to be, because they were diverting those tests to high area needs and also hospitals. So this is very difficult for us, right? It's going to cause issues if we're not actually able to get the tests. Next slide. So a lot of focus has been on these IgM tests, the Henry Schein test, and we're all hoping that this would be the thing that we'd be able to do in our practice. And you can see that the sensitivity only being 81%, the specificity 96%. But like if you look down, the specificity and sensitivity for some of these tests are not where they need to be. Next slide. And the major problem with many of the serological rapid point of care tests is that several-fold. WHO, the World Health Organization, actually doesn't recommend it for clinical diagnosis. It's for research and experimental use right now, and the FDA said the same thing. If you look at this green box, it actually, this is from a package insert. Every single one of those tests has this in their package insert. And it basically says that this test has not been reviewed by the FDA and that negative results don't rule out SARS. And you need to follow up a positive test or any test with a molecular PCR test anyway to rule out infection. So it really doesn't help you that much. The other issue is that multiple coronaviruses are identified, not just COVID-19. There are multiple strains that are identified by these rapid tests. And we still don't know if immunity is proven after illness. There's been cases where some have said that they've had the disease more than once or it's recurred. And is it a recurrence? Is it reactivation? Or is it they're actually getting another strain? We don't know yet. We need more information. And from the Stanford study that just came out this week, if the prevalence really is between 2 to 4%, it's really low, which means that the positive predictive value for the tests, for these serological IgG, IgM tests, is going to be really, really low compared to, what we need it to be. So you could have false positive rates of more than 50%. It could be 50, 80, 90%. I mean, it's just not tenable that, half of the time you could be saying that someone who you think has COVID really doesn't have it. And it's better to just flip a coin. Next slide. So what else can you do? Well, there are other adjuncts to diagnosis, right? Obviously a good history, a good exam, if you're able to do an exam. The use of chest x-ray, in some countries, they've used it as an adjunct, especially when they've not had testing available. And in Asia specifically, and in China, initially in Wuhan, what they did was actually do CT scanning instead of or in addition to the PCR tests that were available because they ran out of PCR tests. So when you look at the results of this study, you can see that many who had positive PCR tests actually had positive CT scans. 88% had positive CT scans. And in those who had negative PCR tests, 75% had positive CT scans. So I think we just went back. So the other thing that's really interesting is that I have Asian family doctors in Asia who are using one of these, point of care ultrasound to look at signs of infection or signs of pneumonia, looking at B lines where you see a rocket sign where it looks like this with the lines coming down as you scan the lung, and areas of consolidation. And they're actually using that in addition to their rapid testing to try and get more idea as to whether that really is a positive test or not. Next slide. So really, who should get tested? We obviously know that a lot of the push has been for hospitalized patients and symptomatic healthcare workers. It was really difficult initially to even get symptomatic healthcare workers their tests. But thankfully now, I know that in California, we've tested about 266,000 tests have been done. When you look at the tests that have been done, they've mainly been done for these reasons in symptomatic patients or those who are over the age of 65. But we know that in areas where more spread is occurring, that it is important to actually check patients who do have symptoms of COVID. And right now, the CDC is not recommending asymptomatic patients be prioritized for testing, especially when we don't have enough tests out there. And the media, we're running out of swabs, we're running out of viral media, to be able to do the testing. And then because the rapid tests for serology are not that accurate at this point in time, it really is going to be interesting to see what our role is in terms of testing. In other countries where they've moved to large scale testing, many family physicians are actually doing testing in addition to they have testing centers or places where you can go for testing that almost look like phone boxes where people stand in there and then test people. We may see the day where family physicians are asked to do those type of testings and really get involved in the public health aspect of it, where we do more contact tracing and things like that. But we have to remember that appropriate and adequate PPE is absolutely essential to ensure that all of us are safe. And so I'll close there and look forward to the questions that come up. Thanks so much.
Great, thanks. Thank you, Kim. Just a quick reminder for those of you who may have just joined us on Facebook. This is the CAFP's Community Conversation, week 3. Happy to have you here and thrilled to have our group of 5 wonderful family physicians here to talk to us about testing, what's happening in their communities, in their organizations, and in their institutions. 1 CME credit for this, and the link will be posted up on Facebook for you to go there. Thanks, Kim, for that overview. Dr. Anthony Fauch-Chong from Scripps Coastal Medical is going to talk to a little bit about the diagnostic and the serology pieces of this testing to go a little deeper for us. Fauch?
Well, actually, probably less deep than Kim. I don't want to repeat the specific detail that Kim went over, which was excellent. I wanted to give a perspective of what's happening in San Diego. You know, San Diego, for many of us here, is a box. We're bordered by the ocean, the desert, Mexico, and Camp Pendleton. So we happen to be in the same box, so we share the same experience. So I wanted to give a perspective of what's happening down here. I wanted to touch base on what's happening with diagnostic tests, and then go a little bit into a summary of what Kim went over on the serology test. So at Scripps Health, which is part of the system that my medical group is part of, we are a very large health system. My medical group comprises of 270 physicians and APC, the majority of which are family medicine physician. Our testing option at current state, there are 3 options. 1, we do have the Abbott POCT test. We have 5 units there at the hospital itself, and primarily are used for inpatient and emergency room patients. Then we have a testing platform called the Hologic unit. It can turn the specimen around in less than 24 hours. And then finally, if we needed to, Quest Diagnostic is available for us as well. We had primarily relied on the Quest lab up until about 2 weeks ago when we brought on the Abbott and the Hologic unit. Quest serves the majority of Southern California. So for a while, they were lagging about 10 days in terms of turnaround time. They've gotten much better. They're now under 48 hours. So all of it are great development. However, you see in the yellow, we have the platform, we have the machine, but we're limited by the supply. We don't have enough swabs, and we don't have enough test reagent. For every single test that we do, you need the reagent, and the reagent right now is in short supply. So while we have the capability of testing really up to 600, 1,000 tests per day, the swab and the reagents are just not available. Next slide. So our priority is really focus on the inpatient or the admitted patient, particularly with the Abbott point of care testing. The results are available within 5 minutes. The negatives are available within 13 minutes. They are particularly helpful with managing the acutely ill. For our outpatient, we're focusing, to Kim's point, on the severe situation. Patient with severe symptoms are whom we are testing, where the results will actually impact the treatment and management of that patient. We've actually been able to expand with the available reagents now to do pre-op clearances for urgent surgeries or care like chemotherapy. And we're now starting to test all OB patients. I think that's a great development. We're still looking for the increase in supply so we can do more testing. We are challenged with what to do about clearing a patient for return to work, especially if they're in a essential employment. The CDC has 2 pathways that you can use to clear a patient, the symptom-based and the treatment-based. The treatment base is problematic in that sometimes patients can be done with the COVID-19 disease, but they're still positive for up to 20 days. So we rely on the symptom base, strict criteria of no symptoms after 3 days. And then we do try to avoid testing in asymptomatic or even mildly symptomatic patient. We actually do not test a lot of ambulatory patients right now at Scripps. Next slide. So as Kim mentioned, there are a lot of requests for serology testing. Again, brief highlight, the WHO does not recommend any point of care serology testing. As Kim mentioned, there's no FDA approved serology tests. All the approved tests in the US are under the emergency use authorization. As of yesterday, there were 4 approved tests, and I'll list them out in a later slide. Bottom line for everybody on tonight's panel recommendation, there's no clear understanding on how to interpret the results of any serology tests yet. It's not well studied for accuracy or validity, and it's not ready to be used in your practice. Next slide. So this came from the Orange County Register. It had the best outline of the headline. An entity from Orange County came down to San Diego and set up a testing tent in the parking lot of the Miracosta JC. And it was quickly shut down by the San Diego County Department of Public Health because they were offering for $125 a nasal swab test and for an additional $75 a antibody serology test, neither of which were FDA approved. So the San Diego County Department of Public Health quickly got involved and closed it down. What we're seeing, particularly important for family medicine, a lot of these vendors are approaching small practices and concierge practices offering these point of care tests or serology tests. And they're unproven. Again, they're not FDA approved, and it's unclear in terms of cost versus benefit ratio for your patient. Next slide. And so, you know, as Kim mentioned, what does an emergency use agreement, so it's actually EUA, again, the test cannot be used for diagnosis or treatment. I want to make sure everyone understands they're not FDA cleared or approved for general use. And no clinically important decision should be made based on the result. And most of the 4 are only available at authorized labs. They're actually part of the emergency use approval asked specifically not to promote this as safe or effective for the detection of the virus. Next slide. And so, you know, what's the big deal? And as Kim mentioned, will serology tests help? No. There are issues with false negative and false positive. The false negative, it's unclear what a positive IgM means. If the sample is done too soon, it's actually going to have low sensitivity. On the false positive side, it's unclear if a positive means that the patient is actually truly protected from an infection or a reinfection. And it's not clear yet whether they're testing for the SARS-CoV-2 virus or your common cold coronavirus. So there's possible cross-reactivity to different corona subtypes. And if you're really interested, next slide, you can go to the CDC website. Mm-hmm. Go ahead, next slide. Yeah, so if you go to the CDC website and search for emergency use authorization, they'll list the companies that have been approved for the emergency use.
Great.
And with that, I'll kick it back to Shelley.
Great, thanks, Dr. Chung. Really appreciate that, particularly from the viewpoint of what's going on in San Diego, one of our large communities. Next up, and if you have questions on Facebook, please post those in the question box, because those are coming to us, and we'll have our panel answer these as soon as we're finished. Dr. O'Connell is going to jump in next. Dr. O'Connell is a residency director at Kaiser Permanente Napa Solano, and he and his residents have been both engaged in testing, and he's been producing a regular podcast, and the latest issue actually of the podcast is about testing. Ted? I think you're on mute.
Thank you for the reminder to take myself off of mute. Thank you, Shelley, for allowing me to be here this evening and provide a perspective from residency director standpoint. As you said, I'm the residency program director at Kaiser Permanente Napa Solano, and have been in regular communication with my colleagues across the state and really across the country through listservs, just talking about how residency programs and medical students too are being impacted by this entire pandemic. We all know that medical schools have essentially moved for their first and second years to essentially a virtual learning atmosphere. Third and fourth year rotations have been put on hold. Some schools are very slowly starting to get back to rotations, but those are few and far between. And so that's really going to produce an interesting effect on our pipeline of future physicians. You know, the longer this pandemic goes on and the longer rotations are on hold, the more clogged our pipeline gets. From a residency standpoint, you know, we're on a CAFP call, so I'm going to speak from a family medicine perspective. Essentially, all of our outpatient rotations have been put on hold because our orthopedic and outpatient cardiology and rheumatology and all those outpatient rotations just aren't, you know, those clinical practices really are almost non-existent. I'm with Kaiser Permanente. We have shifted almost exclusively to a telehealth virtual medicine platform. We were already doing that prior to this pandemic, but have really shifted. So 90% plus of our care right now is happening virtually, so that we can try to keep people out of the medical centers and at the same time provide them the care they need and bring in only the people who really need emergency department care or something in the clinic that we can try to manage for them. The residents have been deployed in terms of doing virtual care, working on the inpatient medicine service, in labor and delivery, in the emergency department, most definitely, and then on some of the inpatient rotations that can still accommodate, you know, that make sense, cardiology and things like that. We have had our residents trained in proper donning and doffing of protective equipment and in testing criteria. It's actually, you know, I think we're all aware that testing for SARS-CoV-2 is changing on an almost daily basis. So it's been a challenge to keep all of them up to speed. And then we've had a couple of residents who've wanted to get out to our mobile testing sites for the drive-up testing and get involved in that. I think Shelley has an image of one of our residents with a couple of our colleagues out doing some testing. So, you know, there's a lot of opportunities within this, a lot of challenges too, but a lot of opportunities to talk about disaster management and systems-based approaches to care and learning on the fly. You know, all of these discussions that we've had this evening already are so rich in terms of how rapidly evolving the idea of testing for SARS-CoV-2 is, as well as for immunity testing. And we're all just trying to keep up and track this. I would personally like to just add on to our first two discussions. You know, a lot of this takes us back to our biostatistics days. But when you're looking, you know, right now we are testing for the most part, you know, throughout California, symptomatic individuals. And in that population, somewhere in the neighborhood of 20% perhaps are testing positive. In our hospitals in Northern California, Kaiser, of the PUIs, the persons being evaluated, it's somewhere in the neighborhood of 7.5% to 8%, and that's for hospitalized patients. So, you know, not a real high number. And then the epidemiologists estimate somewhere between 0.5% and 2% of the general population are infected. That Stanford data that was discussed earlier is indicating somewhere more in the range of 2 to 3.5%. So relatively low prevalence in the general population. And then you take these antibody tests that have sensitivities and specificities anywhere from 38 to maybe 90%. and it makes them very unreliable. You know, as Kim mentioned, it's essentially a coin flip in some cases about whether you can rely on a test. And what we're really trying to do is determine who can safely go back out into the community potentially if they are shown to be immune. But I don't think you want to do that on the basis of a coin flip. You know, will result in another spike here if we're not really, really careful about this. There are now 90 plus tests that are available in this country to test for immunity. 4, as Anthony mentioned, have been released or kind of semi-approved through the FDA under the emergency use authorization. But even those are far less than ideal and have sensitivities and specificities that most of us wouldn't accept for other types of tests. So it's a real challenge to figure out, you know, how to approach this, and not only who should we be testing for SARS-CoV-2, but then how are we going to test for immunity as we start, you know, there's a lot of pressure in this country to start opening up the economy and letting people not shelter in place so much. And the question becomes, how do you actually really, you know, get people back out safely so they're not going to infect themselves and not going to infect people around them? And I think the data that Kim and Anthony shared shows that, like, we don't know what to do with this at this point, and these tests are just not adequately reliable. So it's a real, you know, it's a real national public health challenge.
Great. Thanks, Ted. Thanks so much. And I do have a photo from KP Napa Solano's residency program showing the residents fully garbed and in the tent, trying to help with some of the testing that's going on. Our last panelist tonight, and we are collecting your questions, so we're not ignoring you. And Lee is answering some, and the panelists are answering some, and Lee's keeping track of the queue. Our last panelist tonight is Raul Ayala. Raul is practicing in a more rural community in Selma and is very engaged in the Fresno and Hanford areas, and is going to talk a little bit about what they're doing in a rural community to look at the patient population and the testing and the like there. Raul, thanks for joining us tonight, and congratulations on finishing your degree at Harvard.
Thank you. Thank you all. I just want to thank you. You know, it's a privilege to be with my colleagues here, and we're all friends and family. But I really wanted to take the perspective on, you know, what are we doing in our more rural communities with our vulnerable populations. You know, the panelists earlier talked about, you know, the different testing and what's going on with PPE and et cetera. But I wanted to just give a perspective on an experience. At least, you know, I serve as the medical director for ambulatory care. We have 63 ambulatory clinics across the Central Valley, mainly rural clinics. And you know, a lot of what we're trying to do is really increase the testing, because I know that that's going to be, you know, one of the top 3 strategies long term. I won't get into specifics, but I know that as we started with Adventist Health, we wanted to make sure that we had an ambulatory strategy and looking into our rural communities where we have rural clinics. And one of the important things that I just would like to highlight was, you know, we're not alone. I think, you know, one of the important things is that we can count on our colleagues. We can count on our various organizations. I know that there's conversations that we have with county health directors, other federal qualified health centers. You know, I think the importance is going to be our collaborative work and how do we do that together. One of the examples that we had was when we were trying to think about, you know, how do we even start to test and have, you know, strategies around covering such a large area and geography, is reaching out to our county health directors or county health departments and saying, you know, what are those strategies that you have for the county? And really they were so open, and I'm so thankful that, you know, they have the ability and they have the knowledge, they have the experience in doing, you know, more of the community outreach. And so we partnered with them, and I'll start with Fresno County. In Fresno County, I had conversations, and luckily I was the county health director. We knew each other from training at UCSF here in Fresno, and he's the toxicologist. And so when we started talking, he said, "Hey, we should start testing." I said, "You guys need the test. We need the test. Why don't we do this together?" So what we planned was our first outing in Selma, and we took over the parking lot, and we did a drive-through. They brought their staff. They brought their PPE. We brought staff. They trained our staff. And so we got to really learn about what that community involvement looks like. And, it's not so much of the test in itself, but also, how are the other organizations around the community gathering together and saying, "Hey, if you guys are testing, maybe we should do this together." You decrease the amount of PPE. You engage the other physicians in the communities. There's a lot of family docs that called and texted and said, how do we get involved with some of our patients that we think are in that vulnerable population? They're at higher medical risk. And so that was our first kind of, thought. Now, the other thing that I just want to mention is how important and how strong our local CAFP chapters are. This was a topic of conversation where we said, what are you guys doing around with testing in your organization or that organization or the residency program or et cetera? And that's when a lot of the thoughts and collaborative, and innovation came and saying, what if we reach out to organizations like the Fresno County Health, the Kings County Health, et cetera? And that's when it started really resonating and it started moving people. And I think that's really important that, we highlight the fact that there's so many different people out there in our communities that are doing this, and they probably know a way, and they're probably doing it, and they're probably really good at it. And they are just one phone call away of saying, "No, we'll help you. We'll come over," just like the experience with Fresno County. And what happened with the Fresno County experience was, I asked that Dr. Vora, who is the health director, I said, "Do you know the other health directors around Madera County and Kings County and Kern and Tulare?" And he said, "Yeah, I'll get you those names. I'll shoot an email." And sure enough, what ended up happening was the Kings County health director met us in Selma and said, I'm going to go over and I'm going to take a look and take my staff, because we need to do this next week. And we need to start planning how we're going to do this collaboratively. And they wanted to outreach. They wanted to do more outreach to the federal qualified health centers and other, local docs, private docs, solo docs that can get involved in this kind of collaborative work. And so what we're going to do is everybody's really coming together to test. And I think from an ambulatory strategy, I think that's really important that we emphasize the fact that there's so many of us out there that have such really vast and important experiences and connections and phone calls. And I mean, I just think of Kim right now, and she's got contacts all over the world. And that's just amazing. We really need to emphasize how important it is that we have CAFP, we have local CAFP, our local chapters, our AAFP. And, I know that Foch talked a lot about, the CDC and the other websites. I mean, there's so much information, but I think the personal experiences, that local doc that that's where everything really starts to make a difference at a local level. And that's how we're going to get to the communities that may not have much, or the rural communities. There's also another project that we're working on with the county for the homeless. So we're going to be using virtual clinics, virtual visits to reach out to the homeless. And there is some funding through the county for homeless. And I quite frankly didn't know that that this was available, but I think that's really important, that when you start to collaborate your work, you find out that there's other people that may help you and help those other vulnerable populations that we really don't technically really account for. And a lot of the times, the marginalized populations and people in need are really the ones that we should be doing a lot of our advocacy for. I will stop there, Shelley. I wanted to, just talk about, the experience of collaboration, our contacts, and how important our local chapters and you at CAFP are, because I think that that's really going to get us going in the increased testing that we need. Thank you.
Thanks, Raul, so very much. I appreciate the time all four of you have given us. Lee Ralph has been listening, and I could watch his head go down a little bit when he was writing notes. So I'm sure that he has gathered questions, both from the Facebook group and that he has come up with to ask the panelists. But the first question came out from one of our viewers, Ted. They want to know your favorite record on the wall behind you.
So there's actually a story behind this. These records were my wife's grandfather's, and when he passed, she took a stack of them from the garage. And a few years ago, I made some art, this piece of art behind me, and it's served nicely as kind of a recording studio background. There is a Beatles 45 there, and a couple of other, Linda Ronstadt and a few other kind of, Benny of the Jets is back there. So yeah, thanks that's a great question. That's probably the easiest one we'll get.
Great, thanks. Lee, I'm going to turn it to you because I know you have a couple of questions, and then we also have some Facebook viewer questions.
Well, thank you, Shelley. And I've got a couple. I've been listening intently. I want to thank our panelists for bringing up this important topic that we're all dealing with right now. And I guess I'll just highlight by first saying my impression is that none of our serology testing is ready for prime time yet. I know people keep asking, we've had a few Facebook questions. All right, so we're talking about the testing. We've all kind of said we don't have great sensitivity and specificity. We're not quite sure when to use the serology tests. So a question came in and said, then why bother? And the question that hits my mind is we've got all our national leaders, including Dr. Birx, Dr. Fauci, Governor Newsom, President Trump, all espousing that we're going to test our way out of this problem. And I think those of us in the front line right now sit here and say, wait a second, we're dusting off our epidemiology background, our biostatistics, and my economic statistics that I did in college, and saying, none of these tests, when you put them out there and you remember the old Bayes rules and you go back and look at positive predictive value and negative predictive value, none of these tests really are hitting down to where we say they have clinical practical utility for us in our day-to-day practice. Now, I'm optimistic, and I think when I hear our leaders talking about this, and I'm curious what our panelists think on this, I'm optimistic that we're going to come up with better testing. I think right now, as everyone talked about, you've got 100 companies all out trying to make a quick buck right now. And I know my group, which is a fairly large group in San Diego, we've been approached by numerous biotech companies, many of who were established 6 weeks ago, and have literally come into the market purely to come up with a test quickly, using their contacts oftentimes overseas, mostly in China, who had a little more of a jump start on this, and just trying to do it to make some money and offering us to make money while we test people. And again, I think that gets to the heart as family doctors, why we're not really trying to do this purely to make money for us. We're trying to do this to help our society and understand the problem. So I want to just throw that out to our panelists. Everyone's telling us to test more. Does anyone have any thoughts on where we think we're going to go and where we can get out of this hole that we're in, so we have some understanding? Because I think the serology tests have promised us that if we can somehow understand that they produce some immunity for us, can we then somehow allow certain people to get back into work? Does any of our panelists want to comment on that for me?
I have some thoughts on that, Lee. I think taking it on the macro, the hope here is to try, we're talking about what's the baseline prevalence here, and the hope is that we get to a certain level of herd, so that we can get to herd immunity. And that is what ultimately will allow us to open up society again and open up the economy, is when we get enough people who have either been infected and were minimally symptomatic and survived it and developed immunity. And then once we get a vaccine, what we know from measles, though, is the number for measles is about 95%, that you need to get herd immunity and protect people from that. And when you talk to the epidemiologists with COVID-19, it's somewhere in the 50 to 70% range. And you really hear more like 65, 70% to be safe. And so when you're talking about a background prevalence rate in Santa Clara of 2 to 3.5%, we are nowhere near being able to open up society and get people out and back to work yet. And so then that gets to the next level of, okay, can we test people and say, well, you've been infected and you have IgM, so you're probably immune, although we don't know if titers matter. And you know, there's and then bringing up this issue of these tests are woefully inadequate, and so we don't know if that's even reliable. But let's assume it is reliable. You have probably immunity. Maybe you can go back out and go to work safely without, you know, transmitting and infecting people and potentially getting infected yourself. And then the third level is just kind of knowing what the background prevalence is. So then when you look at these tests and their sensitivity and specificity, it gives you an idea of how much you can rely on those tests. And that gets back to the biostatistics, epidemiology stuff that we all forgot about until the last couple of weeks. So that's how I look at it. But we're not anywhere near being ready. You know, we just don't have the tools and reliable tools at this point to get everybody back to work.
Oh, thanks very much, Ted. I've got a couple other quick questions that have come up from the Facebook post as well. A lot of interest, and I might direct this first to you, Kim. A lot of interest in the Stanford study that we've just been talking about, trying to get a stab at what the prevalence is out in our communities. You know, there was a lot of theories going around that the reason California hasn't been hit quite as hard as the East Coast was because we've had this virus circulating in our population for many months now. And we probably have built up some of that herd immunity. So I look at these Stanford studies that came out and said, well, the prevalence is nowhere near what we think it is. So we certainly aren't anywhere near herd immunity, as Ted just mentioned. But Kim, I'd like you to talk a little bit about that Stanford study. And I know for those of our listeners out here and viewers, there is another LA study that's supposed to come out, I heard on Monday, that's supposed to be randomly selected on individuals and might give us a little more prevalence of Southern California data. My question both to you, Kim, is you could talk a little bit about the Stanford study that I think you know something about, but the other question I have, looking at our biostatistics, if you've got sensitivity and specificity of tests that aren't that good and the prevalence is so low, aren't our values that we're getting even to come up with that 2.5 to 3% probably not very accurate anyways? But Kim, would you like to comment on that?
I really am curious as to what tests specifically, and I will admit I haven't looked deeply into the Stanford study, but what I've read so far, I'd love to know which test they used. You know, because if they're using one of these rapid tests too, then that in and of itself will cause issues, right? With false positive rates and maybe the numbers that they have of 2 to 4% or 2 and 3.5% are actually half of that, you know? So, which would make it even less accurate of a test. The other thing that was really interesting about that study was just the way that people were put into that test. It wasn't just a random survey of people in Santa Clara. They were people that were taken from Facebook or something. They had to self-select into the study. And so you're minusing out a huge population of people who don't use Facebook or internet or whatever to be able to get into the study. So that would really affect your rates and prevalence rates even more so, I would think. Because many might be just on their computers at home, you know, doing effective lockdown compared to others that may be in the community or working at the supermarkets or elsewhere, right? So I thought that was a very interesting observation of their study. And I wonder about the accuracy of that if you're trying to extrapolate to a whole population from just a small selection of people who've selected into that study. And the second thing was really the other thing about the test accuracy, which tests they actually use. And there's going to be so much differences between different communities, as Raul said, you know, compared to a rural community, compared to LA or, you know, different parts of California. We're really going to need widespread testing of a test that, you know, probably more the PCR test is slightly more accurate, you know, as we know, than the rapid tests. And if we had that type of capability to do more of those tests, where instead of just right now we have on the state level about 11% of our tests being positive of the tests that are being done out of 266,000, we have what today, 28,000 or so, 29,000. So say 11%. If we were able to get that down to less than 5%, then maybe we could say we're actually at a point where we could think about you know, loosening up restrictions, but we're nowhere near that at all. We need to do widespread testing as much as we can with tests that are validated and reliable.
Great. Well, thank you, Kim. And I've got one more question. I think I'm going to direct this to Raul or Foch. One of the limitations, I think we've had some questions coming out on the sensitivity and specificity of the PCR tests that we're doing. And the question I had with that is, in our area, as Foch knows, down in San Diego, we are limiting who we have the tests available to. So all of our mild or moderately symptomatic people are being turned away up until this point. We're hopeful now, as Foch mentioned, if we can get some more swabs or reagents, we'll be able to test more people. And Raul, I'm not sure in your area, what we've run into down here is we don't have enough of the PPE for the primary care doctors to be doing the testing in their office. And I would ask Raul or Foch to comment. Do you think that's one of our ways of advancing the understanding of the prevalence of this disease if we take symptomatic people and allow them to be tested in our family physician offices, or somehow having family doctors testing them in drive-through tents? Do you have any questions or solutions to that, Raul or Foch?
I'll if I may, Foch, you know, one of the things that you mentioned there are asymptomatic patients, and you know, from the experience here in Fresno, or at least in the surrounding areas of the Central Valley, you know, a lot of our patients that had priority for testing were either inpatient or were very sick patients. And I think you needed to have like the 3 out of 4, the 4 out of 4, you were a healthcare worker, et cetera. And really the drive-through testing, you know, it's almost like you need a second or third phase of these asymptomatic patients that may have a lingering dry cough, or, you know, they don't have fever, but they may have had a contact, or, you know, these lower risk patients, I think when we start getting into the higher risk medical patients, I think we need to really think about those patients that may be susceptible to ongoing disease, exacerbating disease. So I would like to see, you know, to Kim's point about our availability of testing for maybe that second or third tier is really where we're going to get, you know, our tracks moving into really learning what that real number looks like. Because there is asymptomatic patients that, you know, end up positive, and we tested them because they had either some contact, or, you know, their loved one was hospitalized, or is in you know, was admitted to the hospital, and they get tested. But otherwise, we would have not have known. And from an ambulatory standpoint, at least in family medicine, around our ambulatory clinics, I think that you know, we'd have a major impact by testing our asymptomatic or lower risk patients. I don't know about Foch.
So the challenge with testing asymptomatic or mildly symptomatic is what we went through. The first weekend in March, we stood up at Scripps House, we stood up 3 testing cabana, where patient called in to our hotline, and if they were exposed, whether they had symptom or not, they were sent to our testing, and they were in their car and they got their swab, and we did thousands. And I think our positive rate was something around 5%. And so we were burning through PPEs, swabs, reagents, and Quest was getting inundated, and we couldn't really do the appropriate testing for those who got more symptomatic. I think the second issue with testing asymptomatic or mildly symptomatic patients is going back to statistics and sensitivity. If the patient is barely symptomatic or just starting the infection, you have to do the swab very correctly to even get a chance of getting a positive result. So are they positive because you just lucked out, or they were truly positive, or they were negative because 1, they were too early, and 2, you didn't get the right swab? So I think the idea of now swabbing everybody, given our limited resources, is not the way we should go right now. In the best of world, if we had enough swab, we can swab everybody 2, 3, 4 times a week. But I don't think that's where we are now. I think we have to take a pragmatic look at what we currently have in terms of PPE, swabs, reagent, and do the best public health that we can do. What can you do if you had a positive, mildly symptomatic patient? Nothing. Go home, quarantine yourself, isolate yourself, right? If they're moderately or severely ill, yes, that's the patient where we can actually do something much more. And that's where sometimes in a limited situation like right now is where your tests should be used for the good of the public health.
Very good. Thank you, Foch. I think you brought up an excellent point. I know one of our infectious disease doctors at UC San Diego keeps talking about the importance of analytic sensitivity, which is what the companies report their sensitivity of their PCR tests, versus the clinical sensitivity, which involves taking a correct test, making sure the swab is a good specimen. I have one last question I'm going to throw out there because I'm not sure I'm the right person to answer this, but one of our viewers came up with a question. What about these patients that are testing positive after seemingly recovering, and 20 days later, they've had a negative test at one point, then they come back and they test positive 3 weeks later? Does anyone have a comment on that question or an answer for our viewer?
Yeah, I think that's, I can take the first stab at it. I think this is where the challenge that we're facing with COVID-19 and the SARS-CoV-2 virus. We don't actually know the pathogenicity of this virus, right? So we have patients who work for United Airlines, and United says, we can't let you be a pilot again until you get 2 negative tests. So he's done with his symptom and we retest him, he's still positive. 10 days, 20 days, he's still positive, okay? So now you have an antibody test or serology test. Does that serology test actually mean immunity? And how long does that antibody last? Does it clear the body pretty quickly? Does it even provide immunity? Because what the couple of cases that's happening in South Korea is that these people are getting the virus again. Is it a false positive that they were retested and resymptomatic, or did they just never cleared? That's still an unknown.
Well, thank you, Foch. I think that's a great answer. I'm going to end my questions here and I'll throw it back out, but I think what we've shown today already from hearing all of you speak is the importance of educating our patients on the state of the art of what the data shows. Because I said, they come to us with their questions, they come to us with their fears. And I've got to say, that's what most people are doing now. They're just fearful of what's going on, and they're hoping that a test will prove and alleviate those fears. And it's just not there yet. And I think that's what we're all coming to the conclusion. But I'm going to end my questions at this point. Shelley, if anyone else has other things to add, or if you have other questions, I will leave it to you.
I don't have any other questions. I would like to, however, just sum up what we've heard. We have a couple minutes left. I want to thank everyone for participating and being part of this activity this evening, and thank all of the 50 plus viewers who've been watching on Facebook. What I was struck by as I was listening to this is a series of words that begin with C's. So having champions, and you all have been champions for your communities and your counties. I heard a lot about collaboration. So counties working with residency programs, counties working with medical groups, practices working together in collaboration to tackle this. The CAFP and the chapters, I think we're doing the best we can to give you as much information as possible. We're sorry we didn't get to all of your questions, but we will be putting that information out there. The importance of keeping track about what the CDC is doing. And then finally, the connections that we all make. And when we get to the other side of this mess, I think our final world will be celebration, and we will kind of look back on what we've learned and plan for the next time, and be better the next time, and maybe better prepared. But we will celebrate coming out on the other end with good health for our communities and for our patients. So with that, I do want to close this again. We do have CME credit available. I'm so grateful to the 5 of you for taking time out of a Sunday evening. It is almost 8:30, and we really appreciate that. We know you all have busy days tomorrow. I also want to say that our activity next week on the 26th, we will have Adia Scrub, MD MPP. Adia is a 3rd-year resident at John Muir, about to graduate, and as Ted said, her training has changed significantly over the last 5 weeks. Adia is one of our CAFP Foundation 2019 Susan Hoagland Health Policy Fellows. She's going to actually present her fellowship project. And it's really quite timely because she's been looking at adverse childhood experiences. And we have a sense that there will be some new ACE scores around the COVID experience. And she's going to talk about why we don't look at resilience when we look at ACE scores and some of the resilience factors that we could actually be testing for and what family physicians' roles in that will be. So we hope that you will join us next week with Dr. Shrub and then help each other talk about resilience. Please go to the survey or on Facebook. Just let us know what you want to hear next. This is your hour. We're here to support you. And if you want to have a session on resilience, great. If you want to talk about gratefulness, we'd be happy to talk about that. If you want to revisit testing or telemedicine or any other topic that comes up, please do let us know. We're happy to address these issues for you. The recording from tonight will be available on the CAFP's COVID-19 page, www.familydocs.org. With that, it is 8:31. I want to thank you all again and have a wonderful week this week. Good night.
Thank you, Shelley.